guidelines baru mungkin yang juga sangat berguna untuk peserta didik, baik spesialis 1 maupun juga subspesialis, serta SPA, serta mungkin dokter-dokter lain yang mendengarkan acara ini. Terima kasih pada tim PKB dan juga Dr. Nina yang telah menghadirkan gurunya di hari ini untuk share knowledge beliau dengan kita. Saya ucapkan selamat, mudah-mudahan lancar acara. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Fatima atas sambutannya. Berikutnya kami mempersilahkan Sekretaris Pimpinan Fakultas Kedokteran Universitas Indonesia, Dr. Yuli Budiningsih, Spesialis Forensik, Konsultan. Kepada Dr. Yuli, kami persilahkan.
Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Professor Stephen Graham, expert in international child health from University of Melbourne, the Royal Children's Hospital. Dr. Fatima Safira Alatas, PhD, spesialis anak konsultan, Head of Department of Pediatrics, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo General Hospital. Dr. Nastiti Kuswandani, spesialis anak konsultan, all staff members and residents of the Department of Pediatrics, Faculty of Medicine, Universitas Indonesia, RSCM. Good afternoon, everyone. First of all, I'm delighted to welcome Professor Stephen Graham and all participants who attend this lecture. On behalf of the Faculty of Medicine, Universitas Indonesia, I would like to express my gratitude for the opportunity to collaborate with Professor Stephen Graham from University of Melbourne, the Royal Children's Hospital, Australia. Yeah, it's been almost 3 years since we have lived together with the COVID-19 pandemic. As one of the most affected countries, Indonesia is forced to keep the main focus on handling this current situation. Unfortunately, some of the other microbial threats, especially tuberculosis, have been underestimated and neglected by healthcare authorities, although they endanger millions of lives each year all over the world. Therefore, we are honorable inviting Professor Stephen Graham, who can provide us with updates about tuberculosis in children. We acknowledge your capability through your dedication and achievements in international child health in the African and Asia Pacific regions, including Indonesia. I hope this event is more than just a lecture, but an academic platform for discussion in increasing awareness and updates about TB infections in children. As one of the best medical institutions in Indonesia, we are expected to produce doctors who are professional, responsible, innovative, and able to collaborate inter and multidisciplinary in solving health problems in the field of child infections, especially tuberculosis. For this reason, we need to collaborate with all related institutions to ensure knowledge and information exchange process are still updated between us. I hope through this event, we can strengthen the relationship between our institution. Once again, it is truly an honor to welcome you here today. I hope all participants enjoy this lecture session. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih kepada Dr. Yuli atas kata sambutannya. Berikutnya saya akan mempersilahkan moderator Dr. Nastiti Kaswandani, spesialis anak konsultan, untuk memandu acara selanjutnya. Sebelumnya, izinkan saya membacakan CV beliau. Dr. Nastiti Kaswandani, spesialis anak konsultan, menamatkan pendidikan dokter umum, dokter spesialis anak, konsultan pediatrik respirologi, dan doktor di Universitas Indonesia. Beliau juga sempat mengecap pendidikan di Belanda, dan saat ini beliau merupakan staf Departemen Ilmu Kesehatan Anak FKUI-RSCM. Kepada Dr. Dani, kami persilahkan.
Terima kasih, Dr. Pratama. Selamat siang kepada Bapak, Ibu, Profesor, Dokter, teman sejawat sekalian. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih atas perkenalannya, Dr. Pratama. Siang ini kita sangat berbahagia dan bersyukur bahwa kita mempunyai tamu yang akan memberikan ekspertisnya di bidang pediatrik TB. Beliau seorang yang sangat populer di kalangan pediatrik TB. Sebelum memulai, saya akan membacakan kurikulum vitae Profesor Stephen Graham. Prof. Steve Graham is a professional of international child health with University of Melbourne. He is also a clinician in Royal Children's Hospital in Melbourne. And as a researcher, Professor Steve Graham also works for Burnett Institute in Melbourne. In tuberculosis, especially pediatric TB activity, Professor Steve Graham recently is a co-chair of development of WHO Child and Adolescent TB Guideline. This will become a main issue of this topic. And also he is a consultant of child TB in International Union Against TB and Lung Diseases, or IUATLD. Professor Steve also has huge published articles and also projects, especially in pediatric TB. Prof. Steve, thank you for your time to give us a lecture. So it's now your time to present or to give your lecture. Please, Prof. Steve.
Thank you so much, Dr. Nastiti. And thank you to Prof. Fatima Alatas and Dr. Yuli for the warm welcome. It's a real honor and privilege to be here. I think I need to share my screen. It's a great opportunity for me to be able to be back in Indonesia. I've had the pleasure of being here a number of times. This particular time, I'm here, of course, to work with my colleague, Dr. Nina Putri, who's back to do PhD studies, and also to work with WHO and part of the joint external monitoring mission for the National TB Program of Indonesia. And previously I've had the privilege of working with colleagues at UGM at Yogyakarta and supporting a project in Papua Province, Indonesia, which I will refer to. So I'm going to give a recent update on child TB, and where do I? Yeah. So I want to give, as a clinician, I just want to give a couple of recent clinical scenarios from our work in Melbourne and cover some of the regional epidemiology, and then move to the updates from the WHO updates in the guidance, which I think are particularly important, and my perspective on what's, I think, important for that, addressing the policy practice gaps and moving towards implementation to expand impact. So a couple of cases from our very low TB resource incidence, high resource but low incidence setting of Melbourne. The first one is fairly straightforward. Just a 2-month-old girl who during the COVID epidemic presented with, because was sent in by the Victorian TB program because the grandmother who was visiting Australia to see her new grandchild who had recently been diagnosed with smear-positive TB. The child herself was born in Melbourne and was thriving and well, but has a positive skin test and just had 3 days of occasional cough and a little bit of fussiness with feeds. This child certainly did not look sick. But we did a chest x-ray, and you can see, as you sometimes see in TB, the x-ray looks worse than the child. And that's always a bit of an indicator that this might be TB. And we have to remember that I think that particularly in infants, they can present with quite severe disease acutely. We always associate TB with more persistent symptoms, but in infants particularly, they can get quite rapid progression of disease. And in this particular child, because of the extensive pulmonary disease, we got gastric aspirates, which were positive with expert and culture, but also it was decided to investigate a little further, and she had a few lymphocytes in the CSF already, and we diagnosed her as bacteriologically confirmed disseminated TB. Treatment was commenced, and she did very, very well. So early detection, early treatment, very good outcome, early disseminated bacteriological confirmation. So you can get bacteriological confirmation even in this young age, and I think that's an important message. Now, this is a much more complicated situation of a baby born preterm at 26 weeks, weighing just 995 grams. And this was born to a mother who'd been born in India and migrated to Australia. The mother had IVF, the baby was an IVF baby. The mother had problems with infertility, and she'd also had dry cough throughout pregnancy. She'd had multiple tests for COVID, but nobody ever thought to test her for TB. And then the mother, postpartum, the baby was in NICU, and the mother then presented quite ill with disseminated miliary TB that then involved the CNS. And then it was revealed that she'd had a history of having previous TB some years before, and she also had involvement of the genitourinary tract with TB. So she now had a diagnosis presenting postpartum of disseminated and genitourinary TB. And the baby acted just like a lot of these little babies do initially, and the management was just usual for a very preterm, very low birth weight baby. But once we knew that the mother had miliary TB, we decided immediately to investigate the baby and treat the baby with TB treatment. And then the child deteriorated, whether that was in relation to preterm lung disease or due to the TB. But the important thing was that the baby ended up being, the mother's results came back as being expert XDR fluoroquinolone resistant. So the mother actually had extensive drug-resistant TB. So now we've got a big problem because we've got a baby that we now have to treat for extensive drug-resistant TB, who's just a 1 month preterm baby. And as it turned out, the baby actually had blood cultures and urine cultures, and both were bacteriologically confirmed TB from the blood of the baby, as well as respiratory samples, as well as from nasogastric tube. So this baby had TB bacteriologically confirmed, fluoroquinolone resistant. And I guess when a baby's so preterm, they're quite, with an immature immune system, a disseminated TB, again, there was a high yield for bacteriological confirmation. The challenge, of course, was this baby was just born in January. And at the time, we had to make a decision about what to treat with. And the decision was that we would treat with bedaquiline. We'd introduce bedaquiline and delamanid. Now, bedaquiline and delamanid were only just recommended by WHO at that same week as being able to be used in children under 3 years of age. So the recommendation by WHO that bedaquiline and delamanid, these new TB drugs, could be used in this age group came through the same week as we had to make a decision. This child has been on, I won't go into the details of anti-TB treatment, but the child has been on a range of drugs: delamanid, bedaquiline, cycloserine, linezolid, moxifloxacin, prothionamide. And I saw the baby last week, and the baby's doing very well, and will probably finish treatment next in January. So the baby is now 7 kilos and 10 months of age. So a really challenging case, but highlights a number of different issues, particularly how we can always get good outcomes in children if they're detected and treated, even for extensive drug-resistant TB. So back to the main focus of the talk. TB is a major cause of morbidity and mortality in the Asia-Pacific region. In fact, the Southeast Asian region, which includes Indonesia and India, have some of the highest case notifications globally. And the percentage that are children, on average, is estimated to be around 7%, which is probably lower than you would expect. You would expect it to be more like 10 to 15%. So there is definitely some underdetection, particularly in young children. And the coverage of preventive treatment for young child contacts is actually quite low. It is recommended for a long time that young child contacts of a TB case should be evaluated, case detected and treated, or given TB preventive treatment, and the coverage is a major challenge. So you can see there that Indonesia has the second. Sorry, I'm just getting rid of this so I can see. Yeah, thank you. Has the second largest contribution TB notifications globally, and there are many treatment gaps of all the age groups. The largest treatment gap reported by WHO is estimated to be in young children under 5. And I think we all know why that is. And I think it's because there are the particular diagnostic challenges, trouble getting bacteriological confirmation, clinical overlap with other common presentations in childhood, such as pneumonia, malnutrition, meningitis, etc. But it is an important gap that young children tend to be underdetected and underdiagnosed. We also have this prevention gap, as I said. Most children who are eligible for young child contacts globally do not actually get TB preventive treatment, even those under 5, and certainly very few of older children or adolescents. So there's lots of work to do. If you do detect a child with TB, the overall treatment success is usually good. Children do respond to TB treatment better than adults, whether that's drug susceptible or drug resistant. They have better outcomes, they get less toxicity. And you can see here, for example, this is just some unpublished data from Indonesia, some work that's going on in Papua province, looking at treatment outcomes. And you can see that the best treatment success is actually in children, of cases being detected there. Now, you need to know your epidemic, and this is, I just want to spend 5 minutes on covering this. These are the maps, if you like, of age case notifications from different countries in our region. So the bottom row is children under 15. And you can see the huge variability that happens, even though many of these countries have a similar problem of TB incidence. And you can only sometimes guess why that might be. But in Vietnam, for example, there's and similar to China, very few children are detected with TB. One of the reasons is because children need to get to a large tertiary specialist TB hospital before they will get diagnosis and management. And that centralization of services is a real challenge for access to care and for young children with TB. And clinicians at the primary and secondary care levels don't often have the confidence to make a clinical diagnosis or a bacteriological diagnosis. Cambodia has a rather different problem with a big focus on child TB diagnosis, to the point where I think there's quite a lot of overdiagnosis of child TB. There are children with lymphadenopathy who are being put on TB treatment who probably don't have TB lymphadenopathy, but lymphadenopathy due to other causes. And Indonesia looks a more balanced picture compared to other countries in the region as to what's going on. Now, just as I said, I just wanted to cover quickly, if you have a problem in terms of case detection, that might be because if your case notifications to the National TB Program seem to be low or even too high, there might be a problem of diagnosis and detection, or there might actually be a problem of reporting. So Sassi-Lestari, sorry. So, yeah, so these are the places where you may have the gap. Now, underreporting. So Sassi-Lestari some years ago published this analysis where she did an inventory study in Java, went to various district and private and public settings, facilities, and recorded all the numbers of children who'd been treated for TB, and then compared that to what was being reported to the program. And less than 2% of children who were being diagnosed and treated with TB on Java Island at that point were actually being reported to the National TB program. So there was a massive problem of underreporting. And that was really important study, which has been used as an example globally about the importance of notifying child TB to the national program. Most people are in the habit of notifying smear-positive TB in adults, for example, but at that point, often children were managed in child health services and it was very, very separated or siloed away from TB services. So that's one area. Then you have the problem of underdiagnosis. And then this is exemplified in Laos, where it has a very, very high prevalence of TB in the community, including infectious TB, but very, very, very few children actually notified to the program or even diagnosed or treated. And that's because in that country, they will only give TB treatment to children who are bacteriologically confirmed. And most children with TB, as we know, are not going to be bacteriologically confirmed, particularly in a resource-limited setting. And there's no lack of confidence. There's a lack of confidence there about health workers to make a clinical diagnosis. And then we have the problem of overdiagnosis when you start to give a lot of attention to child TB. And that's been exemplified in Myanmar, which had at one point 10 years ago, a very, very high number of children being notified with TB. But when you looked at the data and carefully, you realize that most of them were actually being diagnosed as pulmonary TB on chest X-ray at all levels of care, right down to the village. And many of those X-rays did not have evidence of TB. So there was a big problem of clinical overdiagnosis of pulmonary TB. Now, this is the recent global report, not the last one, but the one last year, showing that at that point, reporting to WHO at least, that the proportion of child TB in terms of full caseload in Indonesia was 17%, but that the coverage for preventive treatment was actually very low. And there's been an impact of COVID. These are some data, and this has happened in every country. COVID led to a sharp drop in the numbers of cases being detected, particularly in pediatric TB around the world. And also as health workers were diverted from caring for TB to caring for COVID, and preventive treatment for young child contacts also dropped dramatically, as did the detection globally of drug-resistant TB. We already know that only about 17% at best were ever being detected with drug-resistant TB in children, and with COVID that fell back down to 10%. So there's a massive case detection gap in terms of drug-resistant TB, again, with the problems of clinical and bacteriological diagnosis. So I think this is an important slide that just tries to highlight the challenges we have. We have changes across the age spectrum from infancy through to young adulthood for many, many different aspects. And one of them is that the risk of TB disease, if you've been infected, is particularly high in young children and infants, including disseminated and severe forms of TB, such as indicated by the red bar, or pulmonary TB is often lymph node TB, perihilar lymph node TB. And then as you move through the ages into primary school, the risk drops, the numbers should drop. And then as you go into adolescence, particularly through puberty, the risks increase again. And the pattern of disease starts to move towards a more adult type disease with cavities with often bacteriological confirmation. And so we, in children and adolescents, we have to deal with this sort of full spectrum of presentation. So adolescents have been a rather neglected group in TB, but they often do contribute to transmission in the community. It's an age where you have a lot of social contacts, and they often do have, like adults, cavities and bacteriologically confirmed TB. Young children often don't have bacteriological confirmation, but because disease can be severe in that group, and because it's challenging to detect it, TB can be a major problem of morbidity in mortality in those young groups, but they don't really contribute much to transmission in the community. And that's one reason why they've been neglected quite a lot by national TB programs around the world. So moving to the updates. So as you know, WHO, that's one of their main roles is to provide policy documents and guidelines. And what they've done, not just for child TB, but for a whole range of TB aspects, prevention, drug-resistant TB, etc., is that they've moved towards trying to consolidate, updating the guidelines, at the same time consolidating what was in previous guidelines, producing a new versions of consolidated guidelines, which is quite a short document, and then supporting that with an operational handbook, which is a much more extensive document, which aims to try and, so consolidated guidelines tells us what they think we should be doing. Operational handbook on tuberculosis tells us more on how to do it. And this is where things are at now with WHO's consolidated guidelines update. So there's new recommendations, but there's also old recommendations that are still relevant. Now, the main ones, just to summarize from this recent exercise, where all the data was reviewed and people were contracted to go away and do the full literature search with PICO questions and come up with strong data analysis and confidence intervals, etc., to try to answer all of these questions. One was on the use of Expert Ultra for diagnosis. One is on the use of integrated treatment decision algorithms. Then there was an analysis on short treatment regimen for children with non-severe TB. There was an analysis on treatment regimens for TB meningitis. There was PK, pharmacokinetic and safety data presented for the use of bedaquiline and delamanid in infants and young children. You may remember recently, delamanid was only used in children of 3 years and older, and bedaquiline was only used in 6 years and older, at least recommended. And then decentralized models of care were evaluated, and all of this was put together into previous consolidated guidelines, such as including the new shorter TB preventive treatment regimens. So we know that the yield of expert is low in terms of all TB in children compared to adults. So, we know in adults, for example, that smear positive TB smear microscopy will detect around 50%. Expert is more sensitive that will detect around 65, 70%. Culture is the gold standard, around 80%. And then there's still some adults that require a clinical diagnosis. The spectrum in children is much different. Smear will only give you about 10% positivity. Expert increases that to be about 60% sensitivity compared to culture. Culture will only detect up to about 50%, and then you still have to make a clinical diagnosis in many children. So in many settings, you have to make a clinical diagnosis in the majority, and it's recommended to try and get bacteriological confirmation in children of all ages using a range of different samples that now include nasopharyngeal aspirate, stool, gastric aspirate, as well as induced sputum or sputum. But if that expert result is negative, then we still need to make a clinical diagnosis. And in reality, in programmatic settings outside the big specialist centres, the expert confirms disease in only about 20% of children with presumptive TB. So it's not it's not the answer to all our problems with diagnosis, but it is an improvement on what was there before. And the analysis for Expert Ultra has a slightly higher yield than Expert on a range of different specimens, as I said, like nasopharyngeal aspirate in terms of stool, but the specificity is lower. And there is a challenge in interpreting what an Expert Ultra trace result actually means. It is currently within the bacteriologically confirmed diagnosis, but there is some doubt as to whether a trace is just being has lower specificity, more likely to have false positives. So small steps, I think. So we're back to still clinical diagnosis, and most children, as you know, with TB present to child health services, just like other sick children, not to TB diagnostic services. And this is where you have to have strength in your training and support for health workers in those services to think of TB in a sick child and to then be able to evaluate them with confidence for a TB diagnosis. Now, there's been a habit, such as in countries like Vietnam or whatever, that the child has to then be referred to the highest level of care before they'll be diagnosed. But most of these children don't need to be referred. If you go back to this first child that I presented, 2 months old, history of contact, abnormal chest X-ray, that child clearly was going to need TB treatment. The child had enough evidence to treat for TB, whether or not the child was referred. The child wasn't particularly ill. There's also the importance at the primary care level to be able to provide integrated treatment support within the context of families as well. And there is an ongoing reliance still on chest X-ray. The chest X-ray, we've updated the guideline, the union, we've updated a chest X-ray atlas, which is freely available online as a guide to chest X-ray interpretation for child TB, helping to decide whether the X-rays are good quality, good interpretation, penetration, etc., but also laying out all the different types of abnormalities that you might expect for child TB. So I'd recommend anybody interested to go online and download that updated atlas. We know some types of clinical signs are very, very useful in young children particularly, and this is one of them that can be often utilised to document failure to thrive or weight loss. And with the union, we've developed a desk guide for diagnosis and management of TB in children. And this is an example from the old desk guide. The first thing to do is this is aimed at health workers at the primary care or outpatient setting at the district hospital. You first think about the need triage. Does this child so sick that they need to be referred because they may have TB meningitis or severe pneumonia or severe malnutrition or whatever that might be? And then you start thinking about TB suspected on the basis of the symptoms. And you always try and get a sample if you can to help with treatment. And then when you don't have a sample or the sample result is negative, you also start to think about, is there a contact history? Does the child have physical signs suggestive of TB, like enlarged lymph nodes or clinical signs, severe malnutrition? Is the chest X-ray suggestive, etc.? And then when some of those signs are present, make a diagnosis of clinical TB. If not present, follow up again, etc. So this is a fairly straightforward management decision algorithm. Now, the WHO, in their wisdom, this was led by a team from South Africa, from Cape Town. They put together another algorithm and for children under 10, and it looks quite complicated. So you might think this is going to be a bit challenging to implement. And what they also did was that they took data from over 4,000 patients, and they used that data to develop a scoring system. And you can see that scoring system there. Now, one of the scoring systems is for when chest X-ray is also available. And the other scoring system is when chest X-ray is not available and it just relies on signs and symptoms. Now, first, that child would be triaged for severe disease. Then they would look at risk factors for severe disease or rapid progression of disease, like being very young, living with HIV, having severe malnutrition, and some of those children may already be started on TB treatment. If their test comes back, their expert or urine lamb comes back positive, then they should be started on treatment. And also then the history of household contact. And then it's only the others who still haven't ended up on TB treatment or a decision hasn't been made, where then this scoring system is supposedly to be used. Now, it was evaluated and it has a high sensitivity, but a very high-ish sensitivity, but a low specificity. Both of them, the one with chest X-ray has a slightly better specificity, but in trying to make sure that children are not missed, clinically detected with a reasonably high sensitivity, we've ended up with a score that has a low specificity, which means if you follow this, you will end up putting quite a few children on TB treatment who actually don't have TB. There'll be false positives. And so this is the challenge that we have. And this is just showing in better detail so you can actually see it, the sorts of clinical features that are listed or chest X-ray abnormalities with different scores. And, you know, in this context, we need to remember Indonesian Pediatric Society has a TB score. And for a long time, for some years now, WHO has been saying that, and Papua New Guinea has a TB score, Brazil has a different TB score. Many countries have developed TB scores. But WHO has been saying that we don't use scores, we take a more of a management decision approach. But now they come back and said, here's a score. So this is something for discussion. As you can see, I'm a little bit skeptical about how this might be applied in the field by health workers. This is how we've tried to update it for the next version of the union guideline. Again, going back to that management decision algorithm with a little bit more detail to try and walk people through, you know, which questions they should ask. And if they have this yes or no, then move on to the next thing, etc. So that's what we've done in response, but we're not putting in the WHO scoring system. Now, treatment of drug-susceptible TB, this is another major update. Also, it's going to be quite challenging to implement. The new recommendation is that child and adolescents with non-severe drug-susceptible or presumed drug-susceptible TB, you can use a 4-month regimen with just 2 months of the continuation phase of isoniazid and rifampicin. That can be used rather than the standard 6-month regimen, where you use the same 2 months in the intensive phase, but a longer 4-month continuation phase of isoniazid and rifampicin. Now, one of the things that led to this study was the fact that we have managed to develop a much more child-friendly way of giving treatment of the first-line drugs. And there's 2 fixed-dose combinations that are readily available now. One includes rifampicin, isoniazid, and pyrazinamide, and the other one rifampicin and isoniazid for the continuation phase. And the one with rifampicin and isoniazid for the continuation phase can also be used as part of a 3-month TB preventive regimen as well. Now, these formulations are now widely available, and lots of studies have shown that health workers and families prefer these to lots of tablets and breaking up tablets, etc., etc. And one of the good things about this development is that now there's more and more development for child-friendly preparations for second-line drugs as well is now starting to happen, which is great. So the study took these regimens and in a phase 3 open randomized controlled trial decided to compare a 4-month regimen versus a 6-month regimen for non-severe TB in both HIV-infected and HIV-uninfected in 3 sites in Africa, South Africa, Zambia and Uganda, and 2 sites in India. And you can see the way that was randomized. One group received the 6 months, similar number received the 4 months, and the primary outcome assessment was made at 72 weeks follow-up, so 18 months after starting. An uncomplicated pulmonary TB was defined as no significant airway obstruction on chest X-ray, no cavities on chest X-ray, parenchymal disease confined to one lobe, and in children who were not smear microscopy positive on respiratory samples, though they could be expert positive, or children who had peripheral lymph node TB, or, and I forgot to put it there, pleural TB with no other complication. And the primary outcome was unfavorable outcome at 72 weeks. And there was also a safety outcome. So at 72 weeks, this was the outcome. They either had TB treatment failure, TB recurrence, death of any cause, or loss to follow up on treatment. And there was an endpoint review committee that independent that looked at all of the cases and graded them in terms of clinical TB as TB confirmed, TB unconfirmed, and not TB, because some of these children would be considered not to have clinical TB. And the agreement amongst those, that independent expert committee, was very, very high, and about 80% of children in this study was assumed to have TB. About 10% were expert positive. So that was the study population, and these are the results. A very, very clear result, which is that there was absolutely no difference whatsoever in terms of outcomes. So that means that the 4-month is non-inferior to 6 months for non-severe TB, and this has been published. And it doesn't matter which subgroup you analysed, whether it was by age, whether it was by HIV status, whether you used ethambutol or not, or the clinical classification by the endpoint review committee, or whether it was Africa versus India. Remember, Indian children have faster acetylators for isoniazid, etc. But it didn't matter which group you compared, there was no difference in the outcome. So it's considered that this is very strong evidence that 4 months was okay for non-severe TB. Now, the problem is, of course, implementing what is non-severe TB for programs and trying to train all the health workers how to differentiate is really the big issue. So there's been quite a lot of pushback by programs in this regard. Anyway, we need to move on, and I just wanted to mention TB meningitis. Now, the new recommendation here is that if they have diagnosed meningitis, bacteriologically confirmed or clinically diagnosed, a 6-month intensity regimen of 6 months of 4 drugs daily, isoniazid, rifampicin, pyrazinamide, and ethionamide, can be used as an alternative to the current recommendation of 12 months. And this is, but the 12-month regimen remains in place as an option. Now, we know TB meningitis is a really major cause of meningitis in children, particularly now that we have pneumococcal conjugate vaccine and Haemophilus vaccine. It is one of the major causes of meningitis in TB endemic settings. It has a high case fatality because presentation is often late. And even those that survive, many of them are left with lifelong disability. And it is one of the main roles of neonatal BCG is to protect against TB meningitis. So in a country like Papua New Guinea, where you have very low BCG coverage, we see a lot of TB meningitis. Now, this is just to highlight a couple of things, and it includes work done by your colleagues in Indonesia, which show, looking at levels in the CSF. So in those graphs, you can see on the left is levels in the blood at the top for isoniazid, then rifampicin, and then for pyrazinamide. In the D, E, and F, that's levels in the CSF. So isoniazid penetrates into the CSF, but rifampicin at the drug dosages that we use has very poor penetration into the CSF. And then pyrazinamide also penetrates into the CSF. And we know ethambutol does not penetrate the CSF well at all, and we can't increase the dose of ethambutol because if you do, you will get optic neuritis and blindness. We know that fluoroquinolones penetrate the CSF very well, and we know that rifampicin, if we increase the dose, can also get good penetration into the CSF. So these are some of the current issues. What is the right dose of rifampicin? Should we be pushing up the dose of isoniazid? And what should we use instead of ethambutol as the fourth drug. Now, South Africa has quite a lot of experience with that regimen, the 6-month regimen of daily high-dose isoniazid, 20 per kilo, rifampicin, 20 per kilo, pyrazinamide, ethionamide. And the observation there is that their death rate is around 5%, but high neurological sequelae in survivors. Then you compare that to the studies, not in South Africa, in other countries, where maybe the presentation is a little bit later than it is in Cape Town. But never mind, in the old WHO standard of care, the death rates are much higher, but those that survive the sequelae are lower, partly because many of the ones who would have developed sequelae in South Africa actually died in those other studies, probably. Interestingly, a study has just come out, a randomized trial in India and Malawi, where they compared using rifampicin at 30 milligrams per kilogram with ethambutol, then with levofloxacin, versus standard dose rifampicin of 15 milligrams per kilogram in the intensive phase. And what you can find is that the high dose rifampicin of 30 milligrams per kilogram achieved high levels in the CSF, and there was a significant trend to better developmental outcomes. So there was a trend to better, less neurological sequelae in the higher dose rifampicin group. And rifampicin is now being used in some studies in adults of up to 45 or even 60 milligrams per kilogram quite safely. And I think the message really is that for TB meningitis, the best outcome is if you detect it early and you treat intensively with high dose early. It is the early management that makes the difference for the long term. So that's TB meningitis. We've already mentioned that drug-resistant TB, there is now the availability and ability to use bedaquiline and delamidate. Bedaquiline is a particularly good drug. Delamidate is not as effective, but it's still quite a safe drug to use. Can use this so that now children can be treated with drug-resistant TB with all oral regimens for just up to around 12 months. They don't need injectables. They rarely need injectables anymore. Injectables were an absolute disaster for children because they'd often caused ototoxicity and left them with permanent severe hearing loss. So this is definitely a step in the right direction. And other thing that I said before is that we're now getting more and more child-friendly dispersible preparations for young children. Even though the market is actually quite limited, it's great that the companies are prepared to try and develop formulations that work for children. Lastly, decentralization of services. And this is an area I feel very strongly about. But there is this specific recommendation now that decentralized and family-centered integrated services should be implemented to improve detection and uptake of preventive treatment. In other words, move from the tertiary center towards the home and the community to provide care, both detecting TB, but also providing preventive treatment for contacts who are not sick and don't have TB. And they don't replace centralized services, but they complement them. Now, I think we understand the principles of decentralization. Most people present with their health issues at the community or level 1 facility, but the level 3 facility has most of the clever diagnostics and treatment availability. So in the end, you don't have great access to care. And then if you change it and you strengthen and decentralize your services for diagnosis and treatment, you end up with a much greater percentage of people with access to care. So decentralization can lead to earlier detection and treatment, which will reduce morbidity and mortality in children. It's a way of providing better treatment support. Remember that in children, the main negative treatment outcome is loss to follow-up, not death, but loss to follow-up. And so that's an important part of ensuring adherence is treatment support through the whole treatment regimen. It will reduce unnecessary referrals, which reduces costs for families and health systems. And it can provide at the same time active case detection, preventive treatment, and have that integrated with treatment support for the index case or the source case, the adult, for example, who's in the same household. That's the vision I have for decentralization and integration. We did this in a study at the Union in Uganda, and we basically, at the bottom line, that's the baseline, where on the left, where almost all child TB was being diagnosed at the highest level of care. And by training and supporting health workers, we're able to change that. So by integration, it came down to that just 50% went to the highest level of care. And then the others went to primary or secondary level care. And in doing that, introducing that into a number of districts in Uganda, there was an increase in TB case detection in children, but also, interestingly, in adults at the same time. And there was an improvement in treatment outcomes, and there was a successful introduction of community health workers with high uptake and high completion of preventive treatment. So that was a nice model of implementation. And we've been doing similar work in Vietnam, also now in Papua province in Indonesia, led by Sasi Lestari, who I mentioned a little earlier. And she's soon to complete her PhD, which is focused very much on contact management and strengthening health systems to deliver integrated and decentralized TB care. And there's now, based in Uganda, a Child and Adolescent TB Centre of Excellence for the African region. And at the bottom left, that's a team in Mongolia that has been doing household contact management and preventive treatment for children in households with drug-resistant TB. So in Vietnam, they scaled up a focus on preventive treatment for young child contacts over time. And this was supported by community awareness and supporting of the health workers. We all recognize that when you have a well child who needs preventive treatment for 3 months or 6 months, it's often very difficult to explain to a family who has a child who's not sick that the child needs treatment for 3 months or 6 months. And so you need to have some time to be able to spend to explain why you're trying to treat infection and not disease. And so there is need for support for health workers and patient education and information. And the bottom line for this large project in Vietnam was that there was high uptake of preventive treatment. At the time, it was isoniazid preventive treatment, 6 months, and over 20,000 young child contacts were screened, and the completion rates were very, very high. And we introduced for the first time in Vietnam contact screening registers for the program, and also preventive treatment registers, so that the data would be collected and notified to the program. This is just to highlight that a group in Melbourne and also with Menzies in Darwin, and collaborating with collaborators in Papua New Guinea, but also in Indonesia, particularly in Yogyakarta. There's a number of different initiatives funded by the Australian government and also funded by TB Reach in Geneva. And I've already highlighted the work that has been done by Dr. Lestari in Papua province. And these are just some unpublished data. You can see that over the course of this project, there has been an increase in case detection. This is all TB in Mimika district in Papua province. And most of that increase has been through increased detection at the primary care level. And you can see the impact of COVID and then the recovery. And interestingly, I think the impact of COVID was not as strong on primary care as it was on the district hospital, and the recovery was quite good. The impact of COVID in that setting was not nearly as dramatic as it was in many other parts of Indonesia. And even though more and more cases have been detected over time, the treatment outcomes have been maintained throughout, including through COVID. So to me, it speaks to the value of a broad health system strengthening exercise for TB. We can't just isolate TB into silos. It's part of just service delivery for general healthcare in children and adults. In Papua New Guinea, we've had to deal with the problem of a population with a very, very high prevalence of drug-resistant TB. In Daru Island, 1 in 5 people who develop TB have drug-resistant TB. They have 2% of the population has TB at any one time, and 0.6% have drug-resistant TB. And again, a major focus has been decentralization, community engagement, treatment support from health workers, some of whom have had TB themselves, child-friendly services, active case detection in the community, counselling and delivery of treatment out into close to the homes. And you can see that over time, there's definitely been improvements in treatment outcomes for drug-susceptible TB, but also for drug-resistant TB, and much improved just by a concentrated effort in that community. We've also been working, I think, a very important part of training is to embed operational research within TB services, so that the people delivering TB services are always collecting data, looking at their data, seeing how they can improve. This is very much what Dr. Lestari has been doing in Papua, continuous quality improvement, where you come together every quarter, you assess how the situation is, you identify the challenges, you come up with solutions as a team, and you work together to build those over time. And we just last week or 2 weeks ago had our second operational research training. This is the first, this is a photo from the first, just had our second operational research training of health workers from Papua New Guinea from different provinces. So last slide, this WHO has now developed e-course for TB, so training that is available on their NTB channel that anybody can access. And we are doing the same for child and adolescent TB for primary healthcare workers at the moment. That should be finished by World TB Day next year. There is courses online at the union. We have a desk guide developed, which is being updated. And there's that diagnostic chest X-ray atlas. So there is quite a lot out there in terms of tools to help support training of workers. So probably didn't spell terima kasih properly, but I say thank you. And I want to leave you with this last important quote that is just as relevant now as it was when it was first written down many years ago by a leader of TB services in the US. There are many contributions which the pediatrician can make to a TB control program. But first, the negativism that's so about TB that's so prevalent in pediatrics must still be overcome. Thank you. Terima kasih.
Thank you, Professor Steve. You are very good to say terima kasih. We have so many questions, but maybe you need some rest a little bit.
No, I'm good. I'm fine. I'm fine. I'm ready to go. Yeah.
Okay. I already grouped the questions into the questions considered belongs to diagnostic area and also prevention area and of course therapeutic area. So maybe we start with the questions about the diagnostic area first. The questions about how do you suggest about the comparison between TST, which is more affordable, comparing to the IGRA for diagnosis TB in children? The question from Dr. Ricky.
Yeah, do you want to keep asking questions? I'll answer that one now.
Yes, please.
Okay. Yeah, so that's a great question. I mean, tuberculin is not as available as it used to be. We understand that. IGRA is increasingly available because the companies have pushed very hard to market it, but it's usually quite expensive and it does require sophisticated laboratory. The actual performance of skin test and IGRA are really no different. particularly in young children, they both have limitations. So they're not, I would not say that one is better than the other. IGRA is more specific because it's not affected by BCG. But in terms of sensitivity, I wouldn't say that they're particularly different. Interestingly, the WHO now has just endorsed new skin tests and new tests for infection. One of them is a skin test that only has the antigens of IGRA. So that one performs just as well as skin test or IGRA for sensitivity, but has higher specificity than the old TST. So we'll see whether or not these new tests will be taken up in the field. They're going to be cheaper. For example, the new skin test is being produced in India, and it probably will end up being more widely available. I still think that these tests are useful in children where you're uncertain about the diagnosis and you don't have a history of contact. So if you then get a test for infection that is positive, it makes the likelihood that the child's sickness is due to TB disease more likely. But we all know that the sickest children with TB, the TB meningitis, the malnourished children, that skin tests or the IGRAs are often falsely negative, and that's a challenge. So I don't think there's anything new there, Dr. Nastiti. I think we're still going over the same ground we have for many years. Thank you.
Yeah. Thank you, Prof. Steve. The next questions we have predicted before, Prof. Steve, about the scoring systems. So the questions is from Dr. Darmawan and also Dr. Dimas. The questions is about, we know that the diagnosis TB in children is challenging. So many countries you've mentioned before build the scoring system for pediatric TB.
Yeah.
But none give a good performance. So do you have any opinion why the reason that it is very difficult to make the reliable pediatric TB scoring system? So continue with the next question about the scoring system from WHO, when can be applied to a very limited source area, particularly the area with limited source of TST maybe. So which one we should choose, whether the new WHO scoring system or the Indonesian Pediatric Society scoring system that included TST in the scoring system?
That's a very difficult question to answer, both in terms of evidence and politically. You know,
both.
we don't have great evidence. Like when this group analysed this new WHO score, they actually also analysed the Union Desk Guide management algorithm that I put there. And in terms of performance, the Union Desk Guide algorithm was almost as sensitive as the new score, but more specific, had better specificity. So, you know, personally, the challenge with the scores is that they rely on the one hand, they rely on symptoms that are a bit non-specific. So, and that's a challenge we always have. And then they also often rely on, and also chest X-ray findings that can be often very non-specific in children. But then they also rely on tests that may not be available or information that's not available. So not every family wants to tell you about TB contact because there's stigma associated with it. Skin testing may not be available. IGRA is not available. And so it's challenging. This is not a good answer, I know, but my feeling is that it's okay to have these systems developed in your own country. It does give peripheral health workers something to help them think about TB, but they have to always realize that these systems can lead to overdiagnosis. And so you have to be, you have to keep that in mind. You have to realize that these tools are not perfect. But at least if you're starting to think about the possibility of TB in this child who has pneumonia or this child with malnutrition, then at least I think that's a step forward towards improving detection. what we can get with our screening is high sensitivity. Children who are symptom negative don't have TB disease. We have high sensitivity. What we need is a test with much better specificity. And maybe that one day will come with a blood test or something else like that can help us distinguish between all of those children who present with cough and weight loss, which one actually has TB. And that's your challenge. Sorry if that, maybe not a very good answer, but I'm not going to put my money on either approach. Thank you.
Thank you, Prof. Steve. I think your answer is still in line with what we do, that maybe we only use the scoring system in the area when the source is very limited. So if you refer the children, more likely they don't go. So it's there is possibility that missed opportunity to diagnose and to be treated.
Yeah.
So yeah, maybe we move to the diagnostic area in drug-resistant TB that we start seeing the cases a lot. So the questions is from Dr. Cynthia. When the algorithm of diagnostic for drug-resistant TB asking for LPA and culture after diagnosis with expert, but if the sample or the specimen is difficult to obtain in cases, for example, in extrapulmonary TB like spondylitis or brain TB, so what should we do? Whether we do the rebiopsy for the tissue culture specimen, or we just do observation of clinically progress? Yeah,
great question. I think that's a really good question by Dr. Cynthia. So the first thing I would say is we all know that the molecular tests don't have high sensitivity, but if you have them, try them. And even if you only get rifampicin resistant result, that's really helpful as a start. But often you have to make a diagnosis. I'm not sure about how much harder you would try. I think often you need to make a clinical diagnosis even of MDR-TB. And the ones that we treat in a high drug-resistant TB setting like Papua New Guinea, if they're a contact of somebody with drug-resistant TB, then we often will start them on drug-resistant TB. If they have been treated with drug-susceptible TB treatment for a period of time and they're taking their medicine and they're not getting better, then often we will switch to drug-resistant TB treatment. So you have to do both, try to get a bacteriological confirmation, but at the same time, be prepared to make a clinical diagnosis. I presented that very, very small newborn who had positive bacteriological confirmation of fluoroquinolone resistance. If that child didn't have bacteriological confirmation, we still would have treated with fluoroquinolone resistant regimen because the mother had fluoroquinolone resistance. Yeah.
Okay, thank you. So you just mentioned about the quinolone. So there are a lot of questions about the pre-XDR. But before that, there is a question from Dr. Ratno Asi in Surabaya. When do we use quinolone for drug-sensitive TB?
Right.
In what cases? Yeah.
Yeah, that's a great question. And there's a number of settings where we use it in Melbourne. And the main one is when you have TB meningitis, because we don't have access to ethionamide as the fourth drug. And fluoroquinolones cross the blood-brain barrier very well. And so instead of ethambutol, we use levofloxacin. We use isoniazid, rifampicin, pyrazinamide, and levofloxacin as first line to treat TB meningitis. So that's the first one, I would say. The second is if you had isoniazid monoresistance. Now, that's often not detected. And there will be a study done in Vietnam and other places and Australia, which is going to be a randomized controlled trial where isoniazid will be replaced by fluoroquinolone for isoniazid monoresistant TB. I'm not sure how important that is for children, but I do know that quite a lot of people, when they think if there's a problem with isoniazid monoresistance, or multi-drug resistant, then they'll use fluoroquinolone as a first choice. The advantage of levofloxacin is that it's very well tolerated by children and it's very safe. Moxifloxacin, the preparation of Moxi is quite bitter and children don't like taking it at all. So levofloxacin is a better drug in that way. I hope that's useful.
Okay. Can I add the example of cases when we see the abdominal tuberculosis, that is the absorption in the gastrointestinal system is very bad and patient is very severe. So sometimes we give the injectable drug like amikacin and levofloxacin for life-threatening condition. How do you say about it?
Well, I would say that's a clinical judgment that makes sense. I mean, you won't get evidence to support it, but that's okay. I mean, we have to use our sense. And this is one thing I would say is that ethambutol is often used as a fourth drug. It's not a particularly strong drug. And in young children, you know, we have to monitor, if we're going to use it, we have to monitor for eye toxicity, etc. At least you get better penetration with fluoroquinolones, so a better absorption, better levels. So what you suggest would make sense. I think that's okay. Yeah, that's my sense. Yeah.
Yes, you just mentioned the side effect of ethambutol, because there is a participants, Dr. Karina, asked about the optic neuritis after ethambutol. So so what is the regimen you suggest, because the cases is MPMA tuberculosis?
What? Sorry, which?
MPM tuberculosis.
So the cases is MPMA tuberculosis, and the patient suffering from optic neuritis after consuming the ethambutol. So what is your suggestion, whether you change the regimen or just giving the kind of drug, rifampicin, isoniazid, and pyrazinamide?
Yeah. I think most children do not, most young children under 5, and many children don't need ethambutol as part of their intensive phase. The reason I say that is because ethambutol was introduced not so much because it's effective, but because it helped protect against the emergence of drug-resistant TB while being treated. So it's particularly important for adults with cavities, with large numbers of bacilli. It can help stop the emergence of drug-resistant TB to other drugs while being treated. So that's its main role. Now, children mainly have porcibacillary disease. They don't have large numbers of bacilli. They don't have cavities. So the addition of ethambutol, to me, is not necessary in many children, in many children with TB. And so, you know, as I say, I generally leave it for children like young adolescents who may have cavities or smear-positive disease or that sort of thing. Yeah. Okay,
thank you for your answer. So there are 2 questions about the drug-induced liver injury and also the patient that is previously have increased liver enzyme. The first is about the regimen for the patient with the previous increased liver enzyme. What is the regimen you suggest? And the second is, if the liver injury happens after the course and then we stop, how do you suggest to do the reintroduction? Whether you give the same types with 3 kind of drug or one by one, what is your suggestion?
Yeah, I think the reintroduction is fine, and the most likely ones are isoniazid and pyrazinamide that we worry about in terms of causing severe hepatotoxicity leading to hepatic failure. Now, many children, including those receiving preventive treatment, if they receive isoniazid, their liver function tests will rise in about 20%. But almost none of them, it's a problem because it doesn't lead to hepatotoxicity. So we have to distinguish between slightly raised liver function tests and risk of severe hepatotoxicity. But the usual, the ones you worry about are isoniazid and pyrazinamide. That's my own experience. Whereas rifampicin or a fluoroquinolone or ethambutol and some of the other linezolid, these other drugs, not really such an issue. So yeah, that's my perspective on that. If a child has really advanced liver disease and really is highly at risk, then you really have to be careful with isoniazid and pyrazinamide, I think.
Thank you, Professor Steve. It's very clear answer. Now, maybe we move to the questions about the risk factors. The questions from Dr. Rizky Amalia from Jakarta. In high burden TB countries, like maybe in Indonesia, is there any clue when we think that TB cases is related to Mendelian susceptibility or genetic susceptibility to microbacterial diseases, or like another PID, primary immunodeficiency, as an underlying condition?
Yeah. Certainly there is a number of congenital or genetically inherited immune conditions where you have particular susceptibility to, it's usually two pathogens, both important intracellular pathogens. One of them is TB and the other is Salmonella. And there is definitely and I can't remember exactly the immune deficiency, but there's certainly an immune deficiency that's inherited that can make you susceptible to mycobacterial disease, not just TB, but NTMs as well, or Salmonella. But I think it's rare. Well, I know it's rare. In terms of genetic susceptibility more generally in the population, that's the same for any disease. Of course, I think some of us are more susceptible than others, but I don't really know myself. Others may be able to define what that susceptibility is. And one of the challenges, as you know, is that, it doesn't look like it's a major factor, because most populations which have had the same genetics over many generations that were once very susceptible to TB, such as the population that I come from, 100 years ago, TB was a major disease. As they moved out of poverty, as they moved into better socioeconomic conditions, they did not remain susceptible to TB. So I think one of the challenges is when you see TB among certain families, they may share the same genetics, but they also often share the same risk factors and the same socioeconomic challenges and the same transmission issues and many other things. So, yeah, I think it's still an open question. But yeah, in conclusion, I think, of course, we all have slightly different ways of responding to infections. Yeah.
Yes, thank you. Maybe we still need more evidence to see the correlation. Yeah,
we do. But if I could just say that we are very clear about some risk factors for disease. One of them is young age. That is absolutely clear. An immature immune system does not help you deal with TB. We know that young children are very susceptible to severe disease, but also is a child with HIV, so is a child with malnutrition, so is a child who, we have children in Australia who get treated with anti-TNF, anti-tumor necrosis factor treatments for things like Crohn's disease and these other types of immune diseases. And those children are very susceptible to TB. And I've looked after a number of children who've developed TB while on anti-tumor necrosis factor. So there are certainly very strongly recognized groups. But in Indonesia, amongst adults, maybe diabetes is an important comorbidity, probably more so than HIV. So, there are a lot of things we do know about risk. I'm not sure genetics is a major one. That's my sense.
Okay. Yeah, thank you. The next questions about the therapy is also predicted questions from Dr. Stephanie about how are you confident enough to suggest that in Indonesia, we should move to the shorter therapy duration from 6 months to 4 months, like in the new WHO guideline?
Yeah, great question. I don't, you know, it will be hard to implement. It does require some, okay, first we have a problem. It's because it would be probably fairly easy to do this at the sort of hospital level that I'm sitting at today, you know, where you have the resources to look at the chest x-rays, discuss the case, think about it in your TB clinic and make a decision. I think this child's young, he doesn't have severe disease, he only has this, the chest x-ray looks okay, etc. I think you could do it, of course, when you have lots of resources and people sit around and can discuss the case. But when you think of the primary healthcare worker who looks after children and adults, doesn't have a lot of training in child TB diagnosis, maybe doesn't have a lot of training in interpreting chest x-rays, then I think you have a challenge. That's all I can say. That's the way I look at it. And if you have a challenge, maybe the safest thing to do is to keep 6 months as an option, as the default option. You know, so that, yeah, that's my sense. Yeah.
Okay, thank you, Prof. Steve. Still many questions. We have limited.
I bet. I wish I could answer them. I know that I'm not answering them. I'm just talking around them. Yeah.
No, you are answering very clearly. Maybe we should move to the other area about prevention.
Yeah.
The question from Dr. Ratna Napitupulu is about catching up the BCG vaccination for the infants who hasn't received BCG until 8 months. Do you suggest that we need the TST first before giving BCG, or maybe we can directly give BCG for those kind of infants?
Look, I think if there's been no history of contact before 6 months, I think you can happily give BCG. I mean, most babies in the first few months of life, if they get infected, they're going to be infected by somebody who's very close to them. You know, it's not like babies are out in the community like the rest of us, working, going to school, getting on public transport. You know, they're usually just close. So I think if there's no contact, then I think you can do that with confidence. Whereas I think if there's been a contact, then I think you probably first have to establish whether they've got a positive skin test. And if they have a positive skin test, treat them with preventive treatment. And then they don't need a BCG because they've already been infected. So that's my approach. Yeah.
Yeah. Thank you. So the next question is from Dr. Panji Irawan. It's a very difficult question also about the long and winding road, the new vaccine, Prof. Steve.
Oh, yeah.
He asked about the development of MVA-85A vaccine as the new candidate vaccine. What do you say about that?
I think it's showing hope. I think it's great that we have some hope. It's great that 100 years after the first vaccine, we now are starting to see data and studies that are looking at new vaccines. And there has been some publications recently showing, you know, potential. What I would like to say about vaccines is it's great that there's new vaccine development in the pipeline. Whether some of these vaccines can be put together with other, in Sydney, there's a research that's putting a COVID vaccine with a TB vaccine at the same time. These sorts of things are being tried. So I think that's great. What I would like to say, though, is that what I found really hopeful about the recent studies was that they gave these vaccines to young adolescents. Now, young adolescents have a much more mature immune system than a newborn baby. So the newborn baby needs a vaccine to help cover for that first few years of life when they're at risk of TB meningitis or severe disease. But then the vaccine effectiveness wanes within 5 years and drops off. If you give vaccine to somebody who's 12 years of age, they're going to have a much longer, better response and a lot longer duration of protection. So that's the first thing. So we have to start thinking about what age is the right age to give vaccine. The other reason why I think vaccine to young adolescents makes a lot of sense is that the age where you start getting rising of smear positive or bacteriological positive or infectious TB in community is after around 15 years of age. That's when the numbers start going up. So if you want to protect to interrupt transmission in the community and reduce the number of infectious TB cases in the community, you need to focus on preventing TB in older adolescents and young adults. That's a really critical group. So that's why I'd say there is some hope for vaccination or even revaccination. And, you know, maybe we'll get to a point where we end up giving a TB vaccine at the same time as we give HPV, for example, to young adolescents. So that would be my vision. Sorry.
But it's not to propose to replace BCG, right? It's to enhance the older.
Well, I think if we ever end up with a new vaccine that is better than BCG, of course, that should replace it. But the BCG does a decent job in protecting against severe disease in young children, but it also has non-specific effects of immunity that are well recognized in high child mortality settings. So there are benefits to the BCG. Protecting against COVID is not one of them, but that's okay. But, you know, there are non-specific effects of BCG as well. So, but the only way we'll replace BCG is to have a vaccine that is clearly better than the BCG. We know BCG is not perfect, but we need something to give to newborns that is better, higher protection, and longer lasting immunity.
Thank you, Prof. Steve. Now maybe the last is about the TPT. Tuberculosis preventive therapy. We are going to change the regimen from levofloxacin and ethambutol to only levofloxacin for TPT for contact with the RTB. What is your opinion? The first, and the second is what is the regimen for patients contact with pre-XDR cases? What is the regimen of TPT you suggest the patient?
No, great question. So my choice for preventive treatment for drug-resistant TB that is susceptible to fluoroquinolone is just levofloxacin. Now, next year, early next year, you will have data from 2 randomized controlled trials, one in Vietnam and one in adults and adolescents, and one in South Africa in young child contacts, both randomized trials against placebo that look at levofloxacin. And we've been using it in Papua New Guinea. It's safe. None of the children that we put on levofloxacin, not very many yet, but have ended up developing disease. But my preference would be just levofloxacin. I'm not really sure how much ethambutol would actually add. So, but that's my preference. And you have to understand that. We can wait to see the data. If you have, there's another study that's going on that's going to use delaminid and compares delaminid to isoniazid. And delaminid is what some people would suggest for XDR TB or fluoroquinolone resistant TB as a prevention. But there's actually also some evidence from Peru that shows that isoniazid, even isoniazid, may still work in these people who are exposed to drug-resistant TB. So, yeah, it's a data-free zone, as we say. There's not a lot of evidence to support us. We just have to use what we use as first principles and common sense. So, yeah, that's my response.
Okay. Prof. Steve, thank you very much. I think we have 45 minutes, a great lecture from you about clinical aspect and also about public health approach. And after that, we have more than 30 minutes discussion. We go into details, and the practical questions also been answered by you. So we are grateful to have you here. Thank you very much for your time and your expertise. Maybe we should give applause to Prof. Steve. Please give your applause. Begitu cara. Oke, thank you so much, Bapak Ibu, Profesor, Dokter, teman sejawat. Dengan demikian, saya tidak perlu lagi mengambil kesimpulan karena sudah banyak sekali yang sudah kita bahas dan pertanyaan-pertanyaan juga sebagian besar sudah dijawab. Waktunya sudah melebihi dari yang ditentukan. Thank you, Prof. Steve. So, I return it to Dr. Tama.
Baik,
Thank
terima
you.
kasih Dokter Dani. Kita telah sampai pada akhir acara hari ini. Terima kasih kepada Pak narasumber kuliah daring International Guest Lecturer Profesor Stephen Graham dan moderator Dr. Nastiti Kaswandani, spesialis anak konsultan, serta sejawat dokter yang sudah berkenan hadir dalam acara kuliah daring hari ini. Acara kuliah daring ini merupakan kegiatan Departemen Ilmu Kesehatan Anak FKUI-RSCM. Untuk jadwal kegiatan Pendidikan Kedokteran Berkelanjutan Departemen Ilmu Kesehatan Anak FKUI-RSCM dapat dilihat di Instagram @departemen_IK-FKUI-RSCM dan YouTube PKB-IK-FKUI-RSCM. Akhir kata, saya pamit undur diri. Selamat siang, salam sejahtera. Wassalamualaikum warahmatullahi wabarakatuh.
Jangan live dulu, yang mau foto boleh open kamera sama Prof. Steve.
Bisa ya?
Ya. Siapa yang mau foto silakan. Oke, ya. Saya melihat ada Prof. Sofyan. Terima kasih, Prof. Sofyan. Semoga sehat selalu.
Nina.
Prof. Mita.
I can't see you. You have to come forward.
Can you see it, Prof. Stephen?
I'm trying to get Nina. Nina is she's
Yeah.
resistant.
Nina, matikan background-nya aja kalau biar kelihatan. Dr. Vini, Dr. Rina Triasis tadi ada.
Yeah, it's good to see Dr. Rina Triasi.
Sebentar, kita tunggu 1 menit lagi untuk membuka kamera. Terima kasih anggota UKK Respirologi yang sudah bergabung mendengarkan kuliah Prof. Steve. Bapak, Ibu, Profesor, Dokter, teman sejawat dari seluruh Indonesia, terima kasih sudah bergabung di dalam acara guest lecture dari FKUI. Apakah kita bisa mulai foto? Siapa yang mau foto? Residen, terima kasih.
That's great. That's good. That's Rina.
Sudah, sebentar lagi kita tunggu. Ini saya nggak familiar dengan laptopnya untuk print screen apa ya?
Let me take the picture.
Nina, can you take the picture?
Yeah,
Yes.
we'll take it.
Okay.
Everybody smile.
Smile.
Okay, the next.
Stay there.
Stay there.
Cameras up. Cameras on.
Yes. And it's 12 page actually.
Yeah, it's a lot of pages.
Yes. Yeah. Okay. The 6th. And then 7. Eight.
Thank you all for waiting.
And 9.
Almost done.
Almost there.
And currently 11.
Dokter Nina yang itu yang
Last
shoot.
one.
The last one. Iya, Dok?
Nggak apa-apa, lanjutkan.
Okay, the last one.
All done.
Thank you.
Thank you very much for all.
Thank you.
Udah boleh lift, Tama?
Okay.
Oke.
Thank you so much.
Thank
Um,
you.
Yeah.
Saya Dedo.
Dr. Rina.